So there are several antibiotics, you know. Of this sulfonamides was the first therapeutically effective chemotherapeutic agent that was discovered. So sulfonamides is the first one before the penicillin. So after that the penicillin came. So what happens? There are different types of the dyes for dyeing of the textiles. So it has been seen from early 19th centuries that these dyes can cure if there is some infections, particularly if there is some streptococcal infection, for example throat infection, pharyngitis, etc. And then from these dyes, different types of the sulfonamides, ultimately these compounds are developed. So these sulfonamides are group of chemotherapeutic drugs that are previously a part of the dyes that contains a common group. That common group is known as the sulfonamide group. And it has been seen by particularly Domagk. Domagk is a famous scientist who ultimately extract these sulfonamides from the dyes, and it has been seen to be chemotherapeutically very effective, and he received Nobel Prize for this. So these sulfonamides previously used indiscriminately, and after that it has been seen that resistance has developed against these sulfonamides by most of the different bacterial agents. After that newer antibiotics came, penicillin came, other antibiotics came, and the usage of the sulfonamides diminished. But then again at the start of the 21st century, it has been seen that many bacteria become resistant to the other antibiotic agents. For example, these penicillins, these beta-wall effective antibiotics, different other antibiotics. So again it has been seen that sulfonamides are beneficial in many cases. And within the sulfonamides there are one combination, Cotrimoxazole, we read about that, that is very important in different types of the infections. So these are the first effective chemotherapeutic agents. You can see this is the structure. So this is the structure that contains NH2 and SO2. This NH2, SO2, this is the sulfonamide group. So this sulfonamide group is present in all sulfonamides, and their side chains are different, and accordingly the different compounds are developed synthetically. So these are generic name, these are all derivatives of the para-aminobenzene sulfonamide or sulfanilamide that contains this sulfonamide ring, SO2NH2, and they are structurally and chemically related to para-aminobenzoic acid. This para-aminobenzoic acid is necessary for the development of the folic acid, and these folic acids, you know, are very much beneficial both in case of the bacteria as well as the humans for different types of the one carbon transfer reactions. They are also structurally similar to different types of the other drugs, for example diuretics, thiazide, this acetazolamide, dapsone, sulfonylurea. In the diabetes you have read about the sulfonylurea, the structure is more or less similar to this. Physically they are available as white powder, mildly acidic, and form water soluble salts with bases. So the history I have already said that Gerard Domagk in 1932 who first extracted this, and this is the first available commercial antibiotic, and for which in 1939 Domagk received Nobel Prize, and this is known as the Prontosil red. So this is basically a dye. Prontosil red is the congener of the precursor of all the sulfonamides drug, and from this synthetically different other sulfonamides are developed, newer and newer sulfonamides. So this Prontosil was basically broken down to release the sulfanilamide. Sulfanilamide means that contains the sulfonamide group, and then different side chains are attached synthetically and different newer agents are formed. So this is the structure of the Prontosil or Prontosil red, and this is the sulfanilamide, the structures. So we can classify these sulfonamides according to their actions, according to their T-half, duration of action. Short acting sulfonamides, example is sulfadiazine, sulfadimidine, and sulfacetamide. Intermediate acting example is sulfamethoxazole. Long acting example is sulfamethoxypyrazine, sulfadoxine, and sulfadimethoxine. And there are some special purpose sulfonamides, that can be used topically or in case of the ulcerative colitis. Example, mefenide, silver sulfadiazine, and sulfacetamide. Those are used topically, and in ulcerative colitis sulfasalazine can be used. Now coming to the antibacterial properties of the sulfonamides. Sulfonamides as it is bacteriostatic against the different types of the bacteria, and will come later that these sulfonamides can be combined with the trimethoprim to form the cotrimoxazole, and when it is combined with, there will be synergistic effect and they ultimately show bactericidal effect, but itself they are bacteriostatic against both the gram positive and gram negative bacteria, but they achieve bactericidal concentration in the urine. That's why it was very much effective in case of the urinary tract infections. But later, most of the organisms become resistant to this, and again other drugs are commonly used. Susceptible organism are Streptococcus pyogenes, that is causes the streptococcal infections, different types of Haemophilus influenzae, Haemophilus ducreyi, Calymathobacterium granulomatis, Vibrio cholerae, Chlamydia, Actinomycetes, etc. There are few strains like of Staph aureus, Gonococci, Meningococci, Pneumococci, E. coli and Shigella are susceptible to sulfonamides. Within the protozoa, Plasmodium is susceptible to the combination of sulfadoxine and pyrimethamine. Plasmodium, you will read about the different types of the Plasmodium that causes different types of malaria. So this combination is effective against the Plasmodium species, can be used for the treatment of malaria. Toxoplasmosis is another parasitic infection that is caused by the Toxoplasma gondii organism. Again, that are susceptible to the combination of the sulfadiazine and pyrimethamine. And pneumocystis carinii pneumonia is a fulminant form of the pneumonia that mainly happens in immunocompromised persons. For example, if a person has HIV or AIDS, that can be treated by the combination of sulfamethoxazole and trimethoprim, which is known as the cotrimoxazole. So you can see that these sulfonamides, different types of the sulfonamides, can be combined with other agents, and that show promising effects against different types of the organisms. So how the action, how these sulfonamides act as antibacterial agent. So these were first postulated by the Woods and Fields, that's known as the Woods and Fields theory. So what happens? The last part you can see, this is the dihydrofolic acid and tetrahydrofolic acid. So this tetrahydrofolic acid is the active form of the folic acid that is needed for different types of the metabolic actions, different types of the one carbon transfer reaction. Folic acid, active form of the folic acid. And this folic acid can be formed from the para-aminobenzoic acid and pteridine. This para-aminobenzoic acid and pteridine is present in the environment, and bacteria captures this para-aminobenzoic acid and pteridine, and by means of this enzyme pteridine synthase, it converts this to dihydroteroic acid, and this dihydroteroic acid then by means of the dihydrofolate reductase, it is converted to dihydrofolic acid, and again by means of the dihydrofolate reductase, it is converted to the active form of the folic acid, that is the tetrahydrofolic acid, that ultimately leads to different types of reactions, including the different DNA, different forms of the DNA like thymidine, purines, methionine, all this can be formed. So this is the biochemical reactions where the sulfonamides act. So you can see these sulfonamides basically block the pteridine synthase, and again we can add this with the trimethoprim. In the previous we have seen that trimethoprim can be combined with sulfonamides. This trimethoprim blocks here dihydrofolic acid. So bacteria normally picks up this para-aminobenzoic acid from surroundings to synthesize the folic acid. This para-aminobenzoic acid, they mainly captures, it is present in the environment as a chemicals. So inhibition of the bacterial folic acid synthesis from this para-aminobenzoic acid, here this is basically competitive, because these sulfonamides already we have seen, they resemble, the structure resemble like that of the para-aminobenzoic acid. So they comes and attaches with this pteridine. Again, this also blocks the pteridine synthesis. By this two-pronged effect, ultimately the synthesis of this dihydrofolic acid and dihydroteroic acid is decreased. So there will be no active folic acid, and due to the absence of the folic acid, ultimately bacteria dies or bacterial proliferation will be decreased. So this is the basis. The question is, why no humans affect? So in humans also we need the folic acid, we need the tetrahydrofolic acid, but what happens? We cannot synthesize folic acid on our own. We have to use the preformed folic acid, that is the folic acid already present, already formed, that is already present in the different types of the foods that we take, and within our body only this dihydrofolic acid is converted to tetrahydrofolic acid by means of the dihydrofolate reductase. So these biochemical reactions will not happen in our body. That's why even if we are taking the sulfonamides, our folic acid synthesis mechanisms will not be affected like that of the bacteria. So resistance of the sulfonamides, that is the important thing, because since the sulfonamides is used indiscriminately in the past, so resistance has been developed. Staph aureus, gonococci, meningococci, streptopyogenes, E. coli and Shigella, different strains of this have become shown resistance to the sulfonamides. How this resistance develop? First is production of the increased amount of the para-aminobenzoic acid. Since these bacteria need the para-aminobenzoic acid from the surroundings, from the environment for the synthesis of the folic acid, if the production of the increased amount of the para-aminobenzoic acid, it has been seen in some bacteria due to the continuous presence of the sulfonamides, there will be some changes in their mechanism so that they will form more para-aminobenzoic acid that can surpass the sulfonamides concentration, and ultimately sulfonamides cannot block all the folic acid development. Folate synthesis enzyme has low affinity to sulfonamides. This also developed due to the mutations. The affinity will be lower. Adopt alternative pathway of the folate synthesis. Some alternative pathway they have developed, like structural changes in the folate synthesis, mainly in case of the E. coli, encoded chromosome and plasmid mediated. So they need folic acid by any way. So ultimately there are some bypass mechanisms developed, particularly in the E. coli. That's why most E. coli becomes resistant to sulfonamides. And one thing is resistance to one sulfonamide, resistance to all. So there are different types of the sulfonamides, different types of the sulfonamide antibiotics. So if resistance develops to one of these, ultimately it becomes resistant to whole group of some sulfonamides. Now coming to the pharmacokinetics, rapidly and completely absorbed from the gastrointestinal tract. So their absorption in most of the sulfonamides is very good, near towards the 80 to 100%. Extent of the protein binding differs from one sulfonamide to another sulfonamide, 10 to 95%. There are some longer acting agents already we have seen, they are highly plasma protein bound. You know from this pharmacokinetics chapter that if the drug is more plasma protein bound, ultimately the free drug is necessary for its action, and ultimately it becomes long acting because some parts are continuously dissociated from the plasma, becomes free drug, and then it acts. Widely distributed, enters in serous cavity easily, metabolized by the non-microsomal acetyl transferase in liver, and again there are slow and fast acetylators, as I have told in the warfarin class also. So those there are some persons whose genes ultimately encode slow acetylator, and some persons where there is fast acetylator. So if some drugs are metabolized by the acetylation, so in some drugs there will be more metabolized, some will be less metabolized. So ultimately there will be individualistic variations of the pharmacokinetics of these sulfonamides due to this acetylation mechanism. Metabolized by the acetylated product excreted in urine and more toxic than parent. So when the acetylation becomes more, ultimately it comes to the urine, and ultimately they can form some crystal like structure. So this is known as the crystalluria, because this crystal passes to the urine. What happens if the patient will not take more water, that is if there is dehydration, so these crystals can form stone like structure, and so that there will be blockade in the ureter. So that may be a problem. Reabsorbed in tubules, some part of it is reabsorbed back in the tubules. So you can see ultimately there are changes in the T-half. So these are the T-half is the less, and the longest acting is the sulfadoxine, where the T-half is approximately 100 to 230 hours. So very long acting. So first coming to the sulfisoxazole. Sulfisoxazole is rapidly absorbed and excreted with excellent antibacterial activity. Its high solubility eliminates much of the renal toxicity inherent in the use of the older sulfonamides. So same thing, crystalluria. Since it is highly soluble, there are some sulfonamides, they are less soluble. If it is highly soluble, so that there will be less chances of the crystalluria. The kidney excretes approximately 95% of a single dose in 24 hours, and concentration of the drug in urine greatly exceeds than that in blood and may be bactericidal, and the concentration in CSF is that of third in that of the blood. That means if there is some urinary tract infections, we can use the sulfisoxazole oil, because the concentration in the urine becomes more, it achieves more concentration than that in the blood. So if there is infections in the urine, that ultimately leads to bactericidal concentration in the urine. Sulfisoxazole acetyl is basically present in the market in combination with erythromycin ethyl succinate, that is used in children with otitis media. So it is available as a cream also that can be used for the treatment of the otitis media. Next, coming to the sulfamethoxazole. Sulfamethoxazole is a congener of the sulfisoxazole, but its rates of the enteric absorption and urinary excretion are slower. So it is administered orally, employed for both systemic infections and urinary tract infections, more or less similar indications. But again, there is more chances of the crystalluria, known as the sulfamethoxazole crystalluria. That's why patients are usually asked to take more amounts of the water so that dehydration will not happen. Because high percentage of this drug sulfamethoxazole is acetylated and more crystals are formed within the urine. Our clinical usages are more or less same. So this sulfisoxazole and sulfamethoxazole are more or less similar. Next, coming to the sulfadiazine. Sulfadiazine is absorbed rapidly from the gastrointestinal tract. Peak blood concentration achieved within 3 to 6 hours. 55% drug is bound to plasma protein. Both free and acetylated forms are readily excreted by the kidney. And alkalinization of the urine accelerates the renal clearance of the both forms by diminishing their tubular absorption. So if some persons there is more chances of the stone formation or crystalluria, we can alkalinize the urine. For example, we can use the alkazole or something like that. This alkalinization, ultimately the crystal formation will be diminished and the crystalluria will be less. Every precaution must be taken to ensure fluid intake more or less similar, adequate to produce a daily urine output of at least 1200 milliliter and corresponding quantity in children. If this cannot be accomplished, then sodium bicarbonate, what I am telling, that is alkalinization of the urine can be done to reduce the risk of crystalluria. So the common problems of these drugs is the crystalluria. We can reduce this by adequate hydration, and if it does not happen, we can alkalinize the urine. Sulfasalazine. Sulfasalazine is somewhat the pharmacokinetics is different in comparison to the previous three. The previous three are well absorbed, but this is very poorly absorbed from the gastrointestinal tract. It is used mainly in the therapy of the ulcerative colitis and regional enteritis. So these are the some inflammatory bowel disease where there are inflammation occurs in the bowel mucosa. So there are need for the local presence of the antibiotic in the bowel mucosa, not more absorption. So local presence in the bowel mucosa, it is needed. That's why this is needed in the ulcerative colitis and regional enteritis. Intestinal bacteria basically breaks this sulfasalazine to 5-aminosalicylate. This 5-aminosalicylate is the active agent that is needed in the inflammatory bowel disease, and sulfapyridine is basically a sulfonamide that is absorbed and eventually excreted in urine. So basically it breaks down and ultimately it acts some two-pronged effect. Sulfacetamide. Sulfacetamide is another derivative of the sulfanilamide. Its aqueous solubility approximately 90 times that of the sulfadiazine, that is more aqueous soluble. It is mainly used in the management of the ophthalmic infections because it has been seen to achieve very great concentration in the ophthalmic fluid. Very high aqueous concentrations, and they are not irritating to the eye, effective against susceptible microorganisms. So if there is infections within the eye, so we can use the sulfacetamide. The drug penetrates into the ocular fluids and tissues in high concentration. Sensitivity reactions are rare, but it should be avoided if there is any history of the hypersensitivity. So remember, sulfacetamide more aqueous soluble and achieves very high concentration in ophthalmic fluid, that is, it can be used in ophthalmic infections. Silver sulfadiazine. This is another special purpose sulfonamides. It is mainly used topically to reduce the microbial colonization and the incidence of the infections from burns. So if there is burn injury, so there is more chances of the bacterial infections on the skin. So this can be diminished by using some topical agents like topical silver sulfadiazine. It should not be used to treat an established deep infection or deep burns. So mainly if there is some superficial burns like first degree burns, we can use this, but if it is second degree or third degree burns, we should not use this. Here if we are using this silver sulfadiazine, so you can see that there are silver portion and sulfadiazine portion. This silver is released slowly from the preparation and that are selectively toxic to the microorganisms. However, bacteria may develop resistance to silver sulfadiazine. So this silver is also against bacteria, and this sulfadiazine form is also against bacteria. So even if some bacteria are resistant to sulfadiazine, they are susceptible to the silver portions. So that's why silver sulfadiazine, this combination is used. So this is considered an agent of choice for the prevention of the burn infection. So after the burn injury to the skin, for the prevention of this, silver sulfadiazine cream can be used, where both the silver part and the sulfadiazine part acts as an antibacterial agent. Mefenide is more or less similar. It is also used topically to prevent the colonization of burns by a large variety of gram-negative and gram-positive organisms. Not used in deep burns, but there are some problems. For example, the drug and its primary metabolite inhibits carbonic anhydrase and the urine becomes alkaline. So metabolic acidosis with compensatory tachypnea and hyperventilation can happen. So this can happen because there is more absorption, and ultimately some metabolic acidosis like symptoms can develop. That's why it is lesser used nowadays. Next, coming to the sulfadoxine. This sulfadoxine is has very long half-life, as we have already seen, approximately 7 to 9 days, 100 to 330 days, 330 hours. It is used in combination with pyrimethamine. So sulfadoxine plus pyrimethamine, this combination, 500 mg sulfadoxine plus 25 mg pyrimethamine. This is used for the prophylaxis and treatment of the malaria caused by the mefloquine resistant strains of the Plasmodium falciparum. So when we read about the malaria, you will see that many of the Plasmodium species are resistant to different types of the antimalarial drugs. So for example, mefloquine resistant strains of the Plasmodium falciparum, it has been seen to be susceptible to a combination of sulfadoxine and pyrimethamine. So remember, this is important. Sulfadoxine and pyrimethamine is antimalarial drug. Because of the severe and sometimes fatal reactions means Stevens-Johnson syndrome can develop. Stevens-Johnson syndrome means severe hypersensitivity reaction where peeling of the skin can develop, and this can happen with this and the emergence of the resistant strain. The drug has limited usefulness for the treatment of malaria. That is, there is targeted use only in those cases where in spite there are some resistance, then mefloquine is given. Even the mefloquine is become resistant, then we can give the sulfadoxine plus pyrimethamine. So clinical uses, sulfonamides are infrequently used as single agents as of now. Mainly it can be used single agents in case of the burn injury or ophthalmic infections or otitis media. Mainly we can use a fixed dose combination of the trimethoprim and sulfamethoxazole. Trimethoprim, sulfamethoxazole, that is quite important. Adverse reactions, already we have discussed the most problem. These are the common, some hypersensitivity reactions like fever, skin rash, exfoliative dermatitis, photosensitivity, urticaria, nausea, vomiting, diarrhea, etc. can happen. Problem is in relation to the urinary tract, that is the crystalluria that may develop. Urinary tract disturbances, crystalluria in large doses, hematuria or even obstruction, nephrosis, allergic nephritis can happen. In some of the cases, there may be some hematopoietic disturbances like aplastic anemia, granulocytopenia, thrombocytopenia, leukomoid reaction can develop. They provoke hemolytic reaction in patients with glucose 6-phosphate dehydrogenase deficiency. G6PD deficiency is present in some ethnic groups, mostly in the Mediterranean people, but in some Indian people is also there. In those cases, if we are using these types of the drugs, that causes rapid hemolysis. So hemolytic anemia can develop. So end of pregnancy increases the risk of kernicterus. So it should not be given in pregnant women because it increases the chances of the kernicterus, that is deposition of the bilirubin in the basal ganglia in the infant. So Cotrimoxazole is the fixed dose drug combination of the sulfamethoxazole and trimethoprim, and this is very important, and it is used in in some of the diseases which cannot be cured by other antibiotics. This was discovered in 1969. We showed a typical case of the synergism. Synergism means 1 plus 1 greater than 2. So when we are using the two drugs at a time, if that gives just additive result, this is not the additive, that is 1 plus 1, 2. If it is greater than 2, that is more actions are seen individually. The since if we can add the susceptibility to different bacteria, more bacteria are susceptible when we are combining these two. This is known as the synergism. So trimethoprim is usually combined with the sulfonamides. This trimethoprim is a diaminopyrimidine chemically related to the pyrimethamine. So do not confuse, Cotrimoxazole is the Trimethoprim Sulfamethoxazole. But already we have discussed sulfadoxine plus pyrimethamine. This is the anti-malarial drug. These are very commonly asked questions, commonly used. Okay. So mechanism of action, sequential blockade of the folate metabolism will come. This trimethoprim is 50,000 or more times more active against the bacterial dihydrofolate reductase. So already we have seen this structure. So here the sulfonamides block, and in the same chemical reactions downstream to the action where the sulfonamides act, the actions of the trimethoprim happens. So trimethoprim blocks the dihydrofolate reductase by blocking the conversion of NADPH to NADP. So dihydrofolic acid cannot be converted to tetrahydrofolic acid. So when we are combining these two, so ultimately some bacteria that escapes this blockade by the sulfonamides, they will be blocked by the trimethoprim. So ultimately when these two are added, they achieve bactericidal. So individually sulfonamides and trimethoprim are the bacteriostatic. When these two are combined together, they give some bactericidal results. So usually given orally alone or in combination with the sulfamethoxazole, this trimethoprim can also be given intravenously, well absorbed from the gut. It is more lipid soluble than the sulfamethoxazole, and it also concentrates in prostatic fluid and in vaginal fluid. That's why if there is some prostatitis or vaginitis, this cotrimoxazole is very much effective. So you can see this is the pharmacokinetics. When we are using this blue one is the sulfamethoxazole, when we are using this, and the red one is the trimethoprim, and this y-axis is the number of bacteria and the x-axis is the time. So when we are using this individually, they kill the bacteria like this, and when there is no drugs, there will be more bacteria, and when these two are combined, you can see this copper color, there will be very less bacteria, most of the bacteria will be killed. So that's why this is the synergism. This is known as the synergism, which inhibits the growth of the bacteria and causes the bactericidal when these two are combined. So cotrimoxazole, when these two are combined, what are the pharmacokinetics of these two agents individually and how they can be combined? So both drugs have almost similar half-lives, approximately 10 hours. That's why it is very easy to combine these two drugs. Optimal synergism is obtained when we are using 20 parts of the sulfamethoxazole is to 1 part of the trimethoprim concentration, and this minimum inhibitory concentration of both is reduced by the 5 to 6 times. So when we are using 5:1 dose ratio like 800 milligram sulfamethoxazole, 160 milligram trimethoprim, when these two are combined, that achieves in the plasma approximately 20:1 concentration, and that is the minimum inhibitory concentration, that is that kills the bacteria. Because it happens because this trimethoprim has large volume of distribution and enters many tissues, so its plasma concentration is less. That's why you can see that's why we have to use the 160 milligram, 800 to 160 milligram, because this trimethoprim volume of distribution is more than that of the sulfamethoxazole. And there are some differences, like trimethoprim crosses the blood-brain barrier and placenta, sulfamethoxazole not. Trimethoprim is more rapidly absorbed than sulfamethoxazole. Trimethoprim is 45% plasma protein bound, sulfamethoxazole is somewhat higher, 65%, and trimethoprim is partly metabolized in liver. So from this you can say the main main advantage of combining is the half-life. Since their half-lives are more or less similar, and it has been seen if we are giving a specific concentration of drug combined, that achieves the minimum inhibitory concentration at the same time in the blood. So that is the concentration 5:1, and that achieves within the blood 20:1 ratio and ultimately kills the bacteria. What are the spectrum? Spectrum of the antibacterial action is more or less similar to the sulfonamides. Additionally, they also act against the Salmonella typhi that causes the typhoid fever, Serratia, Klebsiella, Enterobacter, Yersinia. Yersinia causes plague, Pneumocystis jirovecii. Sulfonamides resistant strains of the Staph aureus, E. coli, Gonococci, Meningococci, and Haemophilus influenzae. These are also shown to be susceptible to the combination of sulfamethoxazole and trimethoprim, that is the cotrimoxazole. So you can see all the bacteria that are susceptible to the sulfonamides that is present. In addition, these are the other bacteria that are also susceptible to the combinations, cotrimoxazole. Resistance is slow to develop, that's why it is very much beneficial. Even if resistance is developed, that is developed by mutational changes and some plasmid mediated acquisition of the dihydrofolate reductase enzyme. So where it is used, first is the uncomplicated infection of the lower urinary tract. This is most commonly used usage of the Cotrimoxazole, like if there is some cystitis, that is infection in the urinary bladder, chronic and recurrent urinary tract infections in all these cases. So you can see treatment of the uncomplicated lower UTI with Trimethoprim Sulfamethoxazole often is highly effective for sensitive bacteria. So we can use this. Usually single dose therapy 320 mg Trimethoprim plus 1600 mg Sulfamethoxazole in adults has been effective in some cases for the treatment of acute uncomplicated urinary tract infection. Trimethoprim also is found in therapeutic concentration in prostatic secretions, already we have seen, and Cotrimoxazole is often effective for the treatment of the bacterial prostatitis and also bacterial vaginitis. Next, coming to the respiratory tract infections like lower and upper respiratory tract infections, chronic bronchitis, facio-maxillary infections, otitis media due to gram-positive cocci and Haemophilus influenzae. So you can see this is most commonly used for the acute exacerbation of the chronic bronchitis. That is, the patient already have COPD, that is the chronic obstructive pulmonary disease, and there will be acute exacerbation. In those cases, we can use this. Administration of the 800 to 1200 mg of Sulfamethoxazole plus 160 to 240 mg Trimethoprim twice a day appears to be effective in decreasing the fever purulence, that is the pus that is present within the bronchial secretions, and volume of the sputum bacterial count, all these are decreased. But it should not be used to treat the streptococcal pharyngitis because it does not eradicate the microorganisms. So you should know that the streptococcal pharyngitis, if the streptococcus is not fully eradicated, that can go to the heart valves and ultimately endocarditis can develop. So ultimately, if there is pharyngitis due to the streptococcus, we need to fully eradicate the streptococcus. That's why it is Cotrimoxazole is not beneficial here. It is effective for acute otitis media in children. Otitis media, that is within the middle ear there is infections, mostly it happens in the children, and acute maxillary sinusitis in the adults. So there are different sinuses and there may be sinusitis. In those cases, mainly these are done by the Haemophilus influenzae and Streptococcus pneumoniae. In those cases, we can use the Cotrimoxazole. So after the urinary tract infection and respiratory tract infections, the third one usage is the typhoid fever. This typhoid fever, previously Cotrimoxazole is the main drug that is used for the typhoid, but since the newer some drugs have been developed, Cotrimoxazole is lesser used nowadays. Next is bacterial diarrheas and dysentery. On the GI tract, this happens due to the Campylobacter, E. coli, Shigella, etc. So GI infections, they are alternative to fluoroquinolones. You will read about the fluoroquinolones later, which are now the first line agents for the gastrointestinal infections. But if it is not controlled, then we can use the Cotrimoxazole. Effective in the management of the carriers of the sensitive strains of the Salmonella typhi, already have seen, and other Salmonella species. However, failures have occurred. Acute diarrhea due to the sensitive strains of the enteropathogenic E. coli can be treated or prevented. Perhaps you have read about in the microbiology about the different strains of the E. coli. So enteropathogenic E. coli, enterotoxigenic E. coli, you read about this. So this can be tackled by the Cotrimoxazole. Antibiotic treatment of the diarrheal illness owing to enterohemorrhagic E. coli O157H7 may increase the risk of hemolytic uremic syndrome. So if this cannot be used in case of the enterohemorrhagic E. coli infections, mostly done by the E. coli O157H7, because when we are using this, they will release seizure toxin that causes more hemolytic anemia. So there are different types of E. coli. If the E. coli have not yet been done by the microbiology, so when it will be done, you will read that there are different strains of the E. coli like enteropathogenic E. coli, enterotoxigenic E. coli, enterohemorrhagic E. coli, like that. Of this, we can use this against the enteropathogenic or enterotoxigenic E. coli, but not against the enterohemorrhagic E. coli, the Cotrimoxazole. Next is we can use against the Pneumocystis jirovecii infection. Previously, it was known as the Pneumocystis carini. Now it is known as the Pneumocystis jirovecii, that causes some pneumonia-like symptoms, mainly in the immunocompromised persons. That is those persons who have some HIV or AIDS, who have some neutropenia due to some cancer chemotherapy, like that. So severe pneumonia, prophylactic use of the AIDS patients with neutropenia, we can use the double doses tablet 4 to 6 times 2 to 3 weeks. So you can see high dose therapy is needed when there is pneumocystis jirovecii infection. So you can see Trimethoprim in high dose combinations can be used. Adjunctive corticosteroids should be given at the onset of the anti-pneumocystis therapy in patients where the oxygen is less in those patients, less than 70 millimeter, and the alveolar arterial gradient is greater than 35. So pneumonia means there will be consolidation of the alveoli. So the patient will not take the breaths. So ultimately there will be problems, and since there is immunocompromised, these persons are normal immunity cannot fight against this bacteria and against these problems. So we have to give high doses of the antibiotics, particularly this Cotrimoxazole is very much beneficial for the management of pneumocystis jirovecii infection. Other antibiotics are usually not effective here. Adjunctive corticosteroids should be given when the PO2 is very less. Prophylaxis with 800 mg sulfamethoxazole and 160 mg trimethoprim once daily or 3 times a week is effective in preventing pneumonia caused by this organism in patients with AIDS. So when there is HIV/AIDS infection, we have to see the CD4 count, and if the CD4 count is very less, there will be chances of different opportunistic infection of this pneumocystis jirovecii infection is very common. So if the CD4 count is continually decreasing, so we can start with this Cotrimoxazole prophylaxis. Prophylaxis means we are giving the drug so that the disease will not happen. So this can be done here. So for the prophylaxis and treatment of the pneumocystis jirovecii infection, this pneumocystis jirovecii infection occurs in the immunocompromised person, for example in HIV/AIDS person or in neutropenic persons. Neutropenia happens when there are cancer chemotherapy is given. So in those cases it is used, and Cotrimoxazole is now the first line agent for this. Some adverse drug reaction like rash, fever, leukopenia, hepatitis, this can happen. So after this Sancoid, which is caused by the Haemophilus ducreyi, we can use this. Alternative to penicillin in agranulocytosis presence, septicemia. So in these cases we can use. So prophylaxis in neutropenic patients already we have discussed, more or less similar. Miscellaneous infections. There are some typical or specific infections where we can use, like nocardia infection have been treated successfully with the combination, but failures have been reported. So nocardiosis, this can be treated by the Cotrimoxazole. A combination of the doxycycline and streptomycin or gentamicin can be used for the treatment of the brucellosis. Brucella. From the brucellosis can happen. Usually it is transmitted from the domestic animals. So for the treatment of the brucellosis we can use. But now the first line agent is the combination of the doxycycline and some streptomycin or any other aminoglycosides. But if it ultimately not responds, that we can use the Cotrimoxazole. It is also used successfully in the treatment of the Whipple disease. Whipple disease is caused by the Tropherium whipplei, which is an infection of the gastrointestinal tract. Whipple disease. There are some other infections like Staphylococcus maltophilia. Infections by the intestinal parasite like Cyclospora and Isospora. So all this can be tackled by the Cotrimoxazole, and no other antibiotics are beneficial against this. Wegener's granulomatosis, this is a connective tissue disease. It has also been shown to be respond to Cotrimoxazole depending on the stage of the disease. So when you are asked about the usage of the Cotrimoxazole, that is very important. Where we can use the Cotrimoxazole, first one is the urinary tract infections, mainly the uncomplicated urinary tract infections, including the prostatitis, because it achieves very high concentration in prostatic fluid, and again very less antibiotics are effective against the prostatitis. Next is the different types of the respiratory infections. Most common is the acute exacerbation of the COPD, chronic obstructive pulmonary disease, acute exacerbation. It is not controlled by the other antibiotics. We can give the Cotrimoxazole. Then third, we can use in case of the typhoid, but it is lesser used now. Fourth, we can use in different types of the gastrointestinal infections. Different types of the E. coli are the most common that causes gastrointestinal infections, but it should not be used in case of the enterohemorrhagic E. coli infections, because this E. coli bacteria, when the antibiotic is given during destruction, they release large amount of the seizure toxin, and that causes hemolysis. Hemolytic anemia can develop. So it should not be given there. Apart from this can be given some other miscellaneous infection, and this is important because no other antibiotics are very much beneficial against these uncommon infections. For example, nocardiasis, brucellosis, this Whipple disease that is caused by Tropharema whipplei, maltophilia that is caused by Stenophmonas maltophilia, the different gastrointestinal infections by Cyclospora, Isospora, Wegener's granulomatosis, etc., etc. Okay. So, in a nutshell, you can see what this is used and in different types of the indications and different types of the bacteria. For example, it is active against some strains of the gram-positive cocci, Staph aureus. So, it is effective for community-acquired MRSA, skin and soft tissue infections. So, when you will read about the gram-positive cocci, what are the antibiotics against the gram-positive cocci, you read about the different types of the agents penicillin, but the resistance is more. So, that is known as the MRSA, that is the methicillin resistant Staph aureus. So, it has also been seen that Cotrimoxazole is beneficial against this methicillin resistant Staph aureus infection, MRSA infection. This MRSA skin and soft tissue infections, in most commonly we can use again this Cotrimoxazole. Next is another is the gram-positive bacilli. Example is the Listeria monocytogenes. Again, this is effective in septicemia and meningitis that is caused by the Listeria monocytogenes. Because this Trimethoprim part usually enters within the CSF fluid in very high concentration. So again, Listeria monocytogenes can cause listeriosis. This listeriosis is accompanied with meningitis as well as the septicemia. Septicemia means there is more bacteria in the blood. So this can again be tackled by the Cotrimoxazole. So you have to write about the MRSA, listeriosis. Respiratory infections already we have discussed. Within this, another is the Legionella pneumophila. Legionellosis. Legionellosis again a type of the pneumonia. Usually it happens in those rooms where the air conditioning system is not washed for long periods of time. Usually there will be spores of the Legionella, and from this Legionnaires pneumonia can develop. Again, Cotrimoxazole is beneficial against this Legionellosis that is caused by the pneumonia caused by the Legionella. And respiratory other infections we have discussed. Pneumocystis jirovecii we have discussed in detail. Prostate and urinary tract infections we have discussed in detail. Prostate, remember prostatitis. Gastrointestinal infections again we have discussed in details. So these are effective against the gram-negative rods. So gram-negative rods like E. coli, Haemophilus influenzae, Legionella pneumophila, Proteus mirabilis, Salmonella typhi and Shigella species. And these are effective against this Pneumocystis jirovecii, Toxoplasma gondii, Toxoplasmosis. Already we have seen the combinations is very much beneficial for the treatment of the Toxoplasmosis. And there are some other agents like spirochetes, Mycoplasma, Chlamydia, anaerobic organisms that are also beneficial. Chlamydia becomes, we have already seen that is, this is against the chlamydia. So this Sancroid is the penile infection, that is infection happens in the penis that is caused by the Haemophilus ducreyi. So again this is can be treated with the Cotrimoxazole. It is clear how the Cotrimoxazole is very important. Cotrimoxazole, how the Cotrimoxazole acts, that is the mechanism of action. Mechanism of action important, how it is so synergistic action, that is in the same biochemical pathway it causes blockade in the two areas so that there will achieve the synergistic effects. And what are the bacteria susceptible, what are the indications of the Cotrimoxazole. There are some adverse drug reactions, but this is lesser, like some nausea, vomiting, stomatitis, rash can happen. Megaloblastic anemia can happen due to the folate deficiency in some persons where the folate level is very low, otherwise it is rare. Blood dyscrasias already we have seen with sulfonamides, there may be some blood dyscrasias like aplastic anemia, hemolytic anemia can develop. In pregnancy it should not be given because it shows teratogenicity. Neonatal hemolysis, the kernicterus can develop. Methemoglobinemia can develop. Patients with renal disease may develop uremia, because if there is renal disease, so there is more chances of the crystalluria, there is more chances of the block. If there is block, there will be uremia because the urea will not be excreted. So that is the problem. In case of the very elderly, risks of the bone marrow toxicity can also be there with Cotrimoxazole. Diuretics given with Cotrimoxazole have produced a higher incidence of the thrombocytopenia. It has been seen in some of the cases, that is platelet count can be decreased if some diuretic is given. Bone marrow hypoplasia among AIDS patients with Pneumocystis jirovecii infection. It ultimately happens, but ultimately we have to take the pros and cons and we have to use in spite of the different types of the adverse drug reaction. So thank you. This is all about the Cotrimoxazole. Any questions? Already I have said what are the importance of sulfonamides, what are the different types of the sulfonamides. You have to read the names of the sulfonamides, adverse effect of the sulfonamides, how sulfonamides act, and everything about the Cotrimoxazole. Okay.